All right, should we go ahead and get started? See, I think we're at the top of the hour. We have a wonderful number of participants coming on. I see a couple more coming in, but let's go ahead and get started. All right, so I would like to welcome everyone to the Current Cancer Genomics webinar series that's brought to you by the Cancer Genomics Consortium Education Committee. I am Deb Ritter from the Clinical Genome Resource, ClinGen, and the CGC Education Committee, and with me is Dr. Celeste Eno, the chair of the CGC Education Committee. So we're excited to present the second webinar of this season on a topic that has changed the landscape of somatic variant curation, the recently published ClinGen CGC VICC Oncogenicity recommendations. This is now an essential part of the Clinical Genome Resource Somatic Cancer Expert Panel process. It's used in multiple laboratories and institutions, with uptake growing, and is available to curate on platforms such as the Clinical Interpretation of Variants in Cancer, or CIVIC. So how do we curate oncogenic variants? What are some of the nuances that we have learned now that this is in widespread real-world use? We have invited two of the authors of the oncogenicity recommendations, Dr. Paulo Campregher from the Albert Einstein Hospital in Sao Paulo, Brazil, and Peter Horak from the National Center for Tumor Diseases in Heidelberg, Germany, to give an overview of the oncogenicity recommendations and to get some details of it along the way. So before we turn it over, just a few reminders to get us started here. We do have an evaluation survey that we'll send out at the end. We ask that everyone fills that out by December 6th. In addition, CGC members and members only can get PACE credits from this webinar. To receive the credit, you must fill out the evaluation survey. And so we'll give the PACE credit code about 5 minutes from the end, so make sure to stick around. Also, please make sure that your Zoom name, especially if you want the PACE credits, please make sure that your Zoom has your name showing so that we can match those up. Lastly, remember to please put your questions in the Q&A and not the chat so that we can also go through them, and we'll be able to save them and answer them offline as well if at the end for questions. All right, so Paulo and Peter, please take it away.
Thank you, Deb. Thank you for this kind introduction. I would also thank you to the organizing committee, actually, for inviting us and for having this opportunity to present the real-world use of our ClinGen CGC VICC Oncogenicity recommendations. But first, before I start, I would like to mention some conflicts of interest which I might have with companies which do perform NGS or NGS interpretation. And to start us off, I would like to broaden the scope of what we will be talking about today, and start with what we are doing in the process of somatic variant characterization. So usually these processes are quite similar across platforms and users. We start with variant identification, this one being mostly standardized and arithmetically robust procedure. Then we annotate the variant. And the next step, which I will be talking about, is what we call the oncogenicity classification and what this SOP is all about. But nevertheless, I will also touch upon other topics, such as clinical interpretation, based on the oncogenicity classification. And of course, the last step in the process, which is the discussion in the molecular tumor board, being a multidisciplinary conference on what we have found through the molecular diagnostics process. So let me start with reasons why we have been developing these oncogenicity classifications in the first place. So as you might know, before we started working on our classifications, laboratories across the world have been using very different methods of estimating oncogenicity of a specific variant. That led to a large number of different schemes being used and to a heterogeneity in the interpretation of a specific variant. And first reason for us to develop these SOPs were to harmonize all these divergent somatic variant classifications and be able to bring some standardization to the molecular tumor boards, which have to interpret these variants on a regular basis. The next important reason, which has been the definition of oncogenicity for rare actionable variants, which are actually presented to the molecular tumor board, but where the approval has been based on a specific mutations without calling or without specifying the mutation. So as you might know, as a good example, is the approval of alpelisib in PIK3CA mutated breast cancer, where neither the FDA nor the EMA specify mutations. They do specify, so FDA does specify an FDA-approved test, again, being based on the approval study. Nevertheless, the EMA does not do that. So especially in European countries, we faced the difficulty that PIK3CA might be mutated in several different ways and in several different domains, and we could not have a good grasp on what is can be called oncogenic and what not, and which patients should be actually eligible for this approved therapeutic option. So as you see on the right side, there are the variants which have been tested in the phase 3 clinical trial leading to the approval in red, and all the other variants which are quite common, which are rare, but regarded as oncogenic here in white. So these two reasons basically led us to establish the knowledge curation and interpretation standards working group within the Variant Interpretation for Cancer Consortium. This working group has been active from 2020 to 2021 and has been led by Dmitry Sonkin and me. And we were supported by the VICC consortium has been supported by the Global Alliance for Genomic and Health, and we have been supported in the development by the CGC and ClinGen as well. So how did we start developing these SOPs? So we didn't have to go far, but we have to just look across the aisle to our colleagues from clinical genetics who have been doing or performing such variant classifications for small SNVs and small insertion and deletions for some time already, and many of the criteria which can be found in the ACMG AMP Germline guideline are actually applicable to what we are doing in the somatic world or somatic sphere. So we use similar databases for population genetics. We also regard in silico and functional evidence. We look for functional data, and we also have some of these criteria tweaked to be applicable to cancer, such as using databases specific for cancer hotspots or other cancer-specific data. Nevertheless, there are some of these criteria which are not applicable to cancer as such, and can be only used in the germline setting, such as segregation data or de novo data, which does not apply to our world. So we have been able to publish this to 2022, and there are some do's and don'ts. So the scope of the SOP includes basically three do's. So the SOP is focused on classification of oncogenicity of small somatic genetic variants, meaning SNVs and small indels in tumor. The classification of oncogenicity also should be done in the context of a relevant tumor type, and is primarily intended to be used in conjunction with an AMP ESCO-CAP style somatic guidelines. So we're not replacing nor reaching into the sphere of diagnostic, prognostic, or therapeutic value of the variants, but we are only focusing on oncogenicity. And then there are also 3 don'ts. So one of them I already mentioned. This SOP is not intended for determining the diagnostic, prognostic, or therapeutic value of variants. It's not intended for classification of anything else than SNVs and small and indels. So for fusions, copy number variants, and chromosomal structural variants, there are other SOPs being developed, especially within VICC or ClinGen, but nevertheless, this SOP is not suited for those. And it should not be, of course, used for classification of germline variants as such. The framework of the SOP is quite straightforward. We actually decided to use a point-based system to make it more usable or more straightforward to be used in a clinical setting, and the points are assigned on the criteria I already mentioned, and are given points, point-based scores from -8 for the very strong benign criteria to +8 for a very strong oncogenic criterion. And summing the score up, you end up with 5 different classes of variants: benign, likely benign, VUS, likely oncogenic, and oncogenic. And I brought 2 specific examples and to demonstrate some of the like real-world consequences of our SOPs. So first of them is not your typical BRAF V600E variant, but a little bit rarer, nevertheless well-known variant in the kinase domain of BRAF, leading to a loss of kinase activity, being a class 3 variant, and activation of the MEP kinase pathway by CRAF. So you have at least several published evidences, functional evidence showing this activation of caused by these variants. So you have satisfied the criterion OS2, giving you 4 points. Then you have the variant sitting in the kinase domain of BRAF. Again, that's a critical and well-established functional domain, giving you the OM1 criterion. Then you have the 3 supporting criteria based on in silico predictors, the presence of the variant in cancer hotspots, but at low prevalence, but nevertheless, and it's absent from healthy controls. So summing those points up, you end up with a likely oncogenic estimation of this variant, and that might be then used to devise or to base your future therapeutic considerations on this type of a variant. Nevertheless, what seems to be straightforward in one case might not be as straightforward in other cases of variants. So this is a variant which is also a small hotspot variant. It's a FGFR4 variant causing in codon 550, actually better known or better described as a resistance mutations in FGFR treated, FGFR inhibitor treated hepatocellular carcinomas. And again, the wording of our SOP leaves a room for interpretation here, as we define OS2 on the wording of well-established in vitro or in vivo functional studies. So in this case, you have 2 functional studies or 2 in vitro studies showing first that this is a resistance variant. Nevertheless, it leads to activity of the MEP kinase pathway, especially and it leads, of course, to resistance. So it leads to a specific change in the juxtamembrane domain of the protein, leading to resistance. And it's well defined in a study looking at its structural impact. So nevertheless, the jury is still out whether these 2 different studies can be regarded as well-established, reproducible, or robust. Nevertheless, in this case, we could safely judge this variant as functional relevant. And the next point, so this variant basically hits all the points as the variant I mentioned before. Nevertheless, if you start looking at the functional domains, you see that the variant is in the kinase domain. Nevertheless, depending on the literature or on the database you are looking at, there might be different definitions of what the kinase domain is. So actually, this might differ from database to database. The next point is the OP1 criterion again, where we specified this as that all utilized lines of computational evidence support an oncogenic effect of a variant. In the previous example, I showed you that all three used in silico predictors have been showing computational evidence supporting its oncogenic effect. Nevertheless, in this case, if you look at all the available predictors, this is just being an output of the DBNS-FVP 4.3 as shown in VARSAM, for example. You will soon realize that most, if not all, of these variants do not fulfill this criterion, as not all utilized lines of computational evidence align on its functional effect. Again, this might depend on the laboratory where this variant is being classified, and also on the agreement in the community of which in silico predictors might be more relevant and which should be used for evaluation of such a variant. And then the next point, again, the same as in the previous example, is the hotspot OP3 criterion. This states that that particular amino acid change count in cancer hotspots has to be below 10. If you look into the database, you will find out that actually that variant fulfills this criterion. So the V50M variant has 4 tumors being presented in the cancer hotspots database. Nevertheless, these are breast, and so 3 breast and 1 soft tissue cancer, or soft tissue sarcoma probably. Nevertheless, if you start looking in other databases, as our definition provides for that, so if you think that your tumor is not covered well by cancer hotspots, you might start looking in databases like COSMIC. And looking into COSMIC, you will see that this specific variant is covered 12 times. So it does not actually fulfill this criterion, and doesn't even fulfill the OM3 criterion, which would be because it does already fulfill the OM1 criteria. So you would lose some points here. And if you start losing points in our evaluation, this is only the last point being added here by the OP3 criterion. Again, OP3 being supporting criterion with 1 point. And it tells you that it has to be absent from control, so on an extremely low frequency. Again, 2 exomes from 111,000 show this variant, so that might be considered extremely low, but we do not define extremely low especially well in our SOP. So there might be instances where your variant is not absent, but not present at extremely low frequency. So you might be thinking about assigning this point as well. So there is some ambiguity to our classification system. And nevertheless, it allows for clinical use and point-based allocation of this scoring system, leading in a best case to a point count of 9, the same as before. In the worst case, to the assignment of a VUS category in this specific case. So with that, and I would like to switch gears and broaden the scope of my talk to what we are actually using this oncogenicity classification for. And as has been said before, it's been used for clinical interpretation with regard to diagnostic, therapeutic, or prognostic parameters. And for that, most laboratories or most clinicians and molecular tumor boards are used or accustomed to the AMP-ESCO-CAP guidelines published in 2017. Nevertheless, there are other published guidelines, just to mention the ESMO-ESCAT scoring system. And I would also like to mention that there are other guidelines evaluating or other tiering systems, such as those used by OncoGD or CIVIC, as you all know. So there's a heterogeneity within the usage of these guidelines. And to show that they all behave the same or similarly, I'll just boil it down to what we are trying to do in this process. So in this process of clinical interpretation, we are using annotated variants, which have been already assigned a functional relevance by our SOP, to define whether published evidence leads to a priori probability that a biomarker drug entity combination in this context will have clinical benefit in an individual patient based on the published evidence. And to put it into a very basic framework, that's what actually we started doing at the NCT in Heidelberg several years ago. And before the AMP-ESCO-CAP guidelines or the ESCAP guidelines have been published, we are looking at several different layers of information from the published evidence. So we look at sensitivity and resistance of drugs based on a specific biomarker. We look whether they are whether the evidence has been generated in the same or other tumor entities, or whether it was a basket study which might apply to many different entities. And once you have clinical data, you can also stratify across the quality of the clinical data. So what is the prospective biomarker stratified clinical trial, basket trial? What is the retrospective analysis of a large clinical trial, which allows for biomarker-based evaluation? Or was it even a case report or a series of cases where you can also assign some evidence to? There are also other layers of information, so that's preclinical data we use for evidence generation, and we sometimes even can use biological rationale. And to put it into a framework, we have established our own evidence classification framework in Germany, and this one has been adopted by most German networks for precision oncology. So I just wanted to remind you that these evidence level classification system might differ from country to country and from system to system. Nevertheless, as we also published some years ago, they all behave similarly when with regard to definition of what's clinically relevant and what might be used then for treatment of patients. Finally, our ClinGen CGC VICC SOP applies to all of these guidelines. So we can use this ClinGen CGC VICC SOP to evaluate variants before we apply the evidence classification system to them. And it's mostly helpful actually to assign variants to the tier 3, what in the AMP-ESCO-CAP system, meaning variant is not actionable currently, or even to assign the variant to tiers 1 or 2, which is actually actionable, and which might also be relevant for the molecular tumor board. And that's the last point in my talk. So what is the molecular tumor board for? And although this evidence classification system has been highly relevant and helpful for our decision making, nevertheless, there's many more factors and data points we have to consider when recommending therapy for one specific individual in the molecular tumor board. And this cannot be based only on the SOP oncogenicity classification or evidence level framework. It has to take into account many other variables, such as previous therapies, side effects and toxicity of a specific drug, pharmacogenomics, drug availability, which is also a major point in some cases. And with that, you can then finally have a molecular tumor board, and we currently host actually 5 of them at our institution per week. So we are quite busy in our tumor boards and have 50 to 60 patients per week in all these different settings and studies. So how can we speed up the process? So that's the main question we asked ourselves in the last couple of years with regard to assigning these as functional classification systems to our to the variants and processing them in the molecular tumor boards. So luckily, most of the data here lends itself well to automation. I don't say that it's easy, and we encountered several different difficulties in implementing an automated system for classification of variants based on our SOP. Nevertheless, it's possible, and I just wanted to show you one example of such a database based on our classification system. So this has been an effort within the German Centers for Personalized Medicine in Baden-Württemberg, and with the help of our colleagues, we created a web interface which uses the classification system, so that the ClinGen CGC VICC SOP, and allows the user to classify variants, offering them semi-automated pre-evaluation of a variant and storing this information in a database, which is then accessible to all institutions connected to this interface, and can lead to a more rapid classification. So this has been rolled out currently within the Centers for Personalized Medicine. There are 4 of them, 4 university hospitals in Heidelberg, in Baden-Württemberg, and this is also being rolled out across Germany in a larger setting of the German Network for Precision Medicine, and hopefully we will be able to generate data using our SOPs soon. And this will then guide the next version of this SOP with some real world data supporting it. That's how this user interface looks like. If you have your variant, you can annotate it across different databases, and then you can pre-select criteria here on the right. So it chooses some automated criteria, so most hotspot and GNOME-based criteria can be pre-selected. Of course, the most relevant functional classification is based on literature search that cannot be automated as of now, and then you assign evidence. You wind up with a score. So this is a score from 1 to 5, from benign to oncogenic, based on this SOP. So that's my that's the future directions. So we are aware that our SOP is general and needs specification for gene-specific circumstances. So there have been several ClinGen somatic variant curation expert panels created, or VSAPs, to implement gene-specific versions of these SOPs. The oncogenicity classification based on this SOP can be submitted to CIVIC or ClinVar. And as I've shown you, automation is possible either within the VICC or also within other efforts developed by the Wagner Lab, for example, the VACAT that is freely available on GitHub, so everyone can use it. And in summary, I hope I have shown you that this somatic variant characterization as a whole process is a stepwise process, and that the clinical interpretation needs some functional assessment upfront. And this SOP I introduced serves as a functional assessment and allows quality assurance as it enables harmonization of variant classification across different laboratories or institutions. And as an outlook, I think that we should proceed to automating this classification system and developing further gene-specific SOPs, and that will help further standardize our clinical decision-making process in the near future. So thank you again, and I will. You can ask questions in the Q&As. Those will be answered at the end, and Paulo will tell you something more about our efforts. I would like to thank all people involved, especially all members of the VICC Cases Working Group. Dimitri, who has been co-leading this working group, Depiani, and the leaders of the VICC consortium, Alex, Malachi, and Obi, been instrumental in making this SOP, creating this SOP, and publishing this SOP. And then, of course, my colleagues at the NCD Heidelberg in all the networks I mentioned, the German networks, and so on. Well, thank you again. Paulo.
Yes. Hi, everyone. So I'll just share my screen. Can you see it?
Yep, looks good.
Okay. So first of all, I would like to thank for this invitation. It's a great pleasure being here in this webinar with Peter, Deb, and Celeste. And my goal here will be to give some insights about the use of this SOP in the practice, right? So I took a few cases from our lab. These are real cases that we use the guideline for making reports. And my goal is to discuss some nuances, some points that are not very well established, right? And many times we have a guideline, we will face situations in everyday work that do not mirror perfectly the guideline, so we have to make decisions, and that will be my goal here today. So these are my disclosures. And before starting talking about variant curation, I would like to bring a few important concepts when we are making genomic profiling in clinical practice, right? So first important concept is we should remember that cancer is caused by the temporal acquisition of several different genomic alterations. So every time we sequence a tumor, we are dealing with a polyclonal tissue, right? We will see that mostly in differences in allele frequencies. And we should have that in mind. So this is a cause of tumor heterogeneity. Another important cause of tumor heterogeneity is that we are never sequencing pure neoplastic tissue. So we always sequence a mixture of neoplastic and benign or not so benign tissue, such as is showing here. We sequence cancer cells, stromal cells, blood cells, endothelial cells, so on and so forth. So we should also have these in mind. And the third point I want to make is that we are now increasingly identifying diseases that are not necessarily neoplastic, but are caused by somatic mutations. And part of these somatic mutations are very similar to the ones we find when we sequence cancer. So this is another layer of knowledge we should have when interpreting a genomic profiling of a somatic tissue or a tumoral tissue. So bring all this knowledge to practical terms. So what do we find when tumors are sequenced in the lab? So first of all, we find tumoral oncogenic somatic variants, right? The driver mutations. This is actually what we are looking for. These are the most important variants we find. But we also find tumoral non-oncogenic somatic variants. We call them passenger mutations. And one of the goals of this SOP is exactly to try to differentiate what is a driver, what is a passenger mutation based on the oncogenicity score. But we also find non-tumoral oncogenic somatic variants that are in non-tumoral tissue, right? The most well-known of such examples is clonal hematopoiesis. So many times we sequence a tumor, a solid tumor, and we find mutations that are very clearly related to clonal hematopoiesis in DNMT3A, TET2. Other times they're not as easily assigned to clonal hematopoiesis, so we should have that in mind too. We also find non-tumoral, non-oncogenic somatic variants. There will be passenger mutations in non-neoplastic tissue. And we find germline pathogenic variants. What is interesting for us in this context are variants in cancer predisposing genes and germline benign variants, right? So we should be aware that we find all these variants in our analysis of tumors, right? And what is potentially clinically relevant? What is important for us to identify? So first of all, the driver mutation. We should also try to evaluate clonal hematopoiesis if possible. This is not easy to do. And also germline. It's important to say that it's not very clear what is somatic and what is pathogenic and what is germline when we have a sequencing, right? So allele frequency can give us a hint, but it's not always clear. And many times to answer this question, we have to sequence a germline tissue to learn if that mutation is somatic and unique to tumor. Model of one report. This is a lymphoid panel. We do genomic profiling. Normally, the report will have the variants that we consider clinically relevant on a first page or on a table, just like this. And the variants of unknown significance are normally on a table on the top of the page. So it is important sometimes to give more attention to some VUSs, right? The interpretation of variants of unknown significance is a very hot topic today, and we are going to visit a little bit of this question today in this talk. And lastly, before going into the variants itself, it's important to say that in the process of classifying a variant, it's important to comprehend as much as possible its clinical context and significance, and to consider these when reporting, mainly when we're dealing with VUSs, right? Some VUSs deserve more attention than other VUSs. As a reminder, VUSs are not actionable alterations, right? We should not act upon VUSs because these are the variants for which we have no criteria to classify as oncogenic or likely oncogenic, nor benign or like benign. So as a rule, VUSs should not be acted upon. So when we, in our hospital, we have this platform called VARSomics. It was developed at Albert Einstein. And it's a platform for analysis of variants. And it's used for both germline and somatic variants. We have many ACMG criteria already automated here. And we are working, as Peter pointed out, we are also working on automation for some of these VICC guidelines for somatic variants. And so when we have this, when we face a mutation here or a variant, some information comes right away with the variant, right? Only by the fact of annotating the variant and the population frequency make us possible to start fulfilling some criteria, right? And so trying again to be very practical here, I divided the criteria in 3 sets. So the first set will be the very first criteria evaluated. The second set are criteria that we have to do a little more work, and 2 criteria that in practical terms are infrequently used, right? So only by the annotation of the variant, we know if it's a loss of function mutation. Of course, we have to fulfill some other criteria to make sure that this loss of function is really a loss of function mutation, or if it's a synonymous, or if it's a insertion or deletion. And we also have the computational predictors score already available for us at this first time, and the population frequency. So this set of criteria, it's very easy for us to deal with them. Secondly, we have to look for functional domains. We're working on automating that, but this is not automated yet. OM4, if it's on the same residue as another oncogenic variant, the 3 criteria related to cancer hotspots, and the functional study. And OS1 and OP1 are very rarely used in our practice. So now I'm going to bring you some examples of curation of variants. I brought some easy ones, some others that we have to think a little bit about. So this is a 77-year-old male with colorectal cancer with oncogenic variants already classified in APC, TP53 is MAD4, and RAD51C. And we also found this missense mutation in FGFR2, so it's on codon 611. And I did some, this table is for bring all the criteria here in an easy way for people not very used to this criteria. So the REVEL score is 0.83. Internally, we have defined 0.7 as a cutoff for dividing, pointing towards oncogenicity. So above 0.7, we consider positive. So this is 0.83. So it fulfills this criteria. The variant is on tyrosine kinase domain. It fulfills this second criteria, and it's absent from NOMAD. So we could not fulfill any other criteria. So the sum is 4, and we classify this variant as VUS, and it goes just on the top, on the bottom of the report on the VUS table. Now we have a second case. This is a male patient, 34-year-old, diagnosed with acute myeloid leukemia. The cytogenetic study showed a normal karyotype, 46XY. And on the myeloid panel, we found 2 variants. One is the variant in NPM1. It's the insertion of 4 nucleotides. This is the very well-known canonical NPM1 mutation that is already very well characterized to be oncogenic. And we found a missense mutation in FLT3, right? So diagnosis of these patients is AML with mutated NPM1 and risk stratification according to European Leukemia Net favorable risk. So let's curate this FLT3 missense variant. So first, this variant is absent from NOMAD, so it scores 1 point. It is located on the tyrosine kinase domain, goes from 610 to 943. This is 841, so it fulfills the second criteria. When you look for functional studies, we use this is Jackson KB, we use that, and also search in the literature. We learned that there's no functional study for these variants, so has been identified but has not been biochemically characterized, so its effect on FLT3 is unknown. But there is another variant on the same codon, N841I, for which there is a functional study showing that it's activating. And when we apply this VICC guideline to classify this variant, it is classified as likely oncogenic. So we can maybe use the OM4 criteria. That is when we have a variant at the same codon of a known likely oncogenic variant, but in this case, likely oncogenic, as long as the amino acid difference between reference amino acids should be greater or at least approximately the same as for the known oncogenic variant. So we have been using the MIATA amino acid distance. And when we look at the distance between the 2 amino acids of the likely oncogenic variant, the distance is 3.37, and the variant we are curating right now is 3.4. So the distance is slightly higher for the variant we are curating, so we fulfill OM4 criteria, right? So we have this criteria also fulfilled. But when we search at the literature, we found this publication from 2020, where they studied the sensitivity to gilteritinib, that is a FLT3 inhibitor, for many missense variants in FLT3, including the variant we found. And they say that we engineered a subset of diverse, clinically identified FLT3 TKD mutations into BAF3 cells, and confirmed the ability of these mutations to transform to cytokine independence. We next assess the ability of gilteritinib to impair proliferation of these cell lines in the absence of cytokine. So we don't have any demonstration in this paper of the actual result of the proliferation in BAF3 cells, but we have this sentence, right? And we see that this variant is sensitive to gilteritinib. These are examples of 3 variants that are not sensitive. We need much higher dose to inhibit the cell, but the variant we're looking for is sensitive. And in the same paper, they described one patient with AML and the mutation we found that presented a partial response to gilteritinib. So based on this, we have decided to score OS2, but not as a strong as a support. So we gave 1 point. And with that, no, before that, if we look at cancer hotspots, this variant is not there, but it is in COSMIC, right? And we have in the guideline that as long as we have a variant or a gene that is not very well covered in cancer hotspots, we should use other database. When you look at this position at COSMIC, we have about 30 occurrences. 3 variants are the same one we have found, and all the 3 have been described in AML. So with that information, we could use OP3, that is variants below 10, it will be a supporting evidence. Nevertheless, we have in the paper that the rule OM3, that is the moderate rule used in cancer hotspots, cannot be used if OM1 or OM4 is applicable. So we should not use the moderate evidence rule if the functional domain is used. But what about OP3? This is not clearly stated in the paper. If we could use OP3 once OM1 has been scored, right? But we interpreted that this is equivalent. OM3 and OP3 are equivalent rules, so we decided not to use that. But even not using that, we came up with a score of 6 that is likely oncogenic. When we look at OncoKB, they also consider these variants likely oncogenic, although there's no functional studies. So we included that in our table, in the report. And the patient was treated with 7+3, that is chemotherapy for AML, plus midostaurin, that is a FLT3 inhibitor, and is in complete remission for 1 year now, right? And now I want to bring this last case. So this is a female patient, 70 years old, diagnosed with AML, myeloid panel with 3 variants, DNMT3A, PTPN11, TP53. The exact diagnosis will depend on the curation of this TP53 variant, because if we consider this oncogenic, according to the international consensus, this will be classified as AML with mutated TP53. If we go through DNMT3A, no big problem. So Revel 0.95. When we look at NOMAD, we see 23 allele for this variant, no homozygous. What caught the attention is the low allele frequency we see in most of these variants. In most of these variants, increasing in frequency as population gets older. So our interpretation is that probably this is clonal hematopoiesis. And so but even being clonal hematopoiesis is very rare. And so we score this OP42. It is on a functional domain, and there is one functional study positive. So the score total is 8. So this is a likely oncogenic mutation. PTPN11, same thing, absent from NOMAD, Revel 0.95. It is located on a protein domain, and there is one functional study. So it's 0.8, likely oncogenic. And this variant has also been curated by a panel of experts. And so it is not very difficult. But what about the TP53 mutation that is delink? So on position 218, delinks a la MET, right? So this is a variant that increases one amino acid in the entire TP53 protein. It is located on the protein domain. It changes the protein length of TP53, and it's absent from NOMAD. The codon 218 is a cancer hotspot, but the variant we are curating is not there, so we cannot use this criteria. It's very important to make a diagnosis of AML with mutated TP53, because as we can see here, this is the worst prognostic, the AML with the worst prognosis. So it's very important to be able to classify this variant. And when we look at the cytogenetics of this patient, the patient has a complex karyotype with deletion of chromosome 5 and 7. And we know that there is a very high correlation between complex karyotype and TP53 mutations in AML, varying among studies from 70 to 90% of complex karyotypes would have some TP53 alteration. So we felt strongly that this variant was probably oncogenic, but we couldn't find enough criteria to classify it as likely oncogenic. So the variant was classified as a VUS, but a text describing all our findings was included in the report. So the hematologist can take his decisions. And this is also discussed on weekly tumor boards we have. So we have the geneticists, molecular biologists, the morphologists, and the clinicians every Tuesday in the same room. So the best approach for these patients can be defined. So conclusions, the adoption of the oncogenicity standard operating procedure is crucial for adequate somatic variant classification in cancer. Each variant should be classified according to the oncogenicity score, and we should, as much as possible, to look for its potential clinical impact and take that into consideration. And the work of ClinGen, VICC is fundamental for clarification of nuances specific for each gene. So I'd like to thank all the team at Hospital Albert Einstein. This is the team from the lab doing most of this work of variant curation. This is the bioinformatics team. And with that, I finished. This is our research institute. If you happen to be in Brazil, you're welcome to visit us. And now I think we can open for questions. Thank you very much.
Great. Thank you so much for both of the talks. And it's great to have the introduction and then also to have really these real world applications for it as well, because I know the more use it gets, the more of these kind of nuances come up and the more we're understanding about it as well. So we had some great questions here in the chat and then in the Q&A. So I'd like to just pull up a couple of these. Let's start with what I called here. It's kind of, it's not exactly on the oncogenicity SOP, but it is about one of the criteria that's given, and that's about this, which databases. So here this talks about the COSMIC database and the cutoff for it. And I know some users have, said it has to be the cancer hotspots database, although it does say other databases are relevant, but how do you know and what cutoffs should you use?
Yeah, I can start. Yeah, that, as you said, that's a very relevant question. I also already had some comments on that. So basically, we only assess cancer hotspots also for the reason that it's actually frozen. So it's basically it does not acquire more data, or not. So the version which we are using yet. So
yes.
it will be expanded. So nevertheless, other databases such as Cosmic might are more flexible, so they increase in size. So the number-based cutoffs which we are using for cancer hotspots do not necessarily apply. And of course, we are aware of that. And I would say that we would recommend a frequency-based cutoff for other databases, and especially if those databases are in cases where the cancer hotspot is underrepresented for the specific entity you're looking at. So that's true for most hematological malignancies. The cancer hotspot does not include those so doesn't represent them very well. But nevertheless, that might be also true for many other rare tumors with time. So I think that there are ideas about addressing that, and I think the most relevant idea would be that if we are if you would have to define a second version of this SOP, you taking into account frequency-based counts and not absolute counts in a specific database. So, but currently there are no clear-cut recommendations, as there are gene-specific VSAPs which do that, which do provide frequency-based cutoffs for specific gene and specific databases. Nevertheless, the general SOP does not.
Yeah, I would like just to make a comment about that. Totally agree with Peter. We use basically 3 databases. We use Cosmic, CBioPortal, and Genie. So we are internally working on the cutoffs. As Peter mentioned, this is not being well defined, and the VSAPs are dealing with that. But these 3 databases are very useful. There are several thousands of cases. And we should be aware that Cosmic, we have a lot of benign variants in Cosmic, so it should be very well curated. And yeah, that's it. These are the 3 databases we use.
Great. So we do have, I need to also put up the link for our